Live, sir.
Okay. Uh, Good morning, students. Today, I have been told to um, discuss about prostatic uh, prostatic pathology, prostatic problems, and retention. There are so many things we can say about prostate, but I have mainly concentrated on the BPH, benign prostatic hyperplasia, because I think this is the most common thing that questions come about prostate in exam, and teachers ask about prostate is BPH because prostate carcinoma is not very common in undergraduate, and also in your day-to-day practice you need to know about BPH. So, and also urinary detention, how to diagnose, manage, how to so these two topics we will discuss today because prostatic uh, pathology is a vast chapter. But I just wanted to concentrate on these two today, and let's see. So I am presenting a. I have taken some slides from Sir Dr. Nitin Kekre. He is a very renowned urologist. So this is a very good slide. Uh, Case one is a 60-year-old man, 6 months history of lower urinary tract symptoms. Now, what is lower urinary tract symptoms? Lower urinary tract symptoms are patients' complaints of frequency, urgency, uh, straining during micturition, then intermittency, hesitancy. So these are all very new words maybe for you. Frequency means patient complaining of frequent urination. Less than 2 hours, he cannot hold urine more than 2 hours. Urgency means he cannot hold. There is compelling desire to pass urine. He cannot hold urine. And hesitancy means difficulty in starting urination. Patient goes to the toilet and waiting, urine is not coming. Nocturia means more than 2 times urination at night after going to sleep. So these are many symptoms. So we commonly patient presents with this sort of lower urinary tract symptoms. Now, I should say something about IPSS score. We categorize the patients with IPSS score. It may come as a short note. Uh, IPSS score is International Prostate Symptom Score. So it is three category. There's less than 8, 8 to 19, and more than 20. So here the symptom, there are different symptom scores are there. IPSS score, AUA symptom score. These are all theoretical. The most common is the IPSS score. So here I have put a picture of International Prostate Symptom Score. So this is a sheet. This is a chart. This comes with symptoms. These all symptoms. These are incomplete emptying, sense of incomplete ending, frequency, intermittency, urgency, weak stream, staining, and it has been described. What is the what does it mean? And there is a gradation. According to the gradation, there is patient self assess his status and all the marks he adds here, and after that you sum the sum total of the total marks is done. So it is a digital representation of the symptoms. Then the patient can self-assess his condition, his improvement, his deterioration. So this is accepted worldwide, and on the basis of this uh, score, we uh, plan the treatment options. We prognosticate the patients. So now the symptom score, the advantages of symptom score is objective assessment of symptoms. The patient can assess, and although the physician can assess. Sometimes patients says that I am very good, I am urinating very well, but the actual picture is something different. So this is the objective assessment of the symptom, evaluation of the effectiveness treatment. You can assess your treatment whether it is improving or the condition of the patient is deteriorating. Compare different therapies. You can compare different therapies, determine the number of individuals in a community who may potentially benefit from therapy. So it's a community level treatment protocols are made on the basis of IPSC score, and it can predict progression. So it's a objective representation of the symptoms of lower urinary tract of the patients with prostatic pathology, or I can say the lower urinary tract symptoms patients conditions. Now the these sort of patients, when come, it may come as a clinical problem to you. As I started the presentation, the 60-year-old male comes with such and such problems. How you manage? These sort of questions come in the theory and also in the practical. So these lower unit tract symptoms patients, how will you manage? The initial evaluation, first of all, you have to take history. The nature of urinary tract symptoms, I told you that the two types of symptoms, some are obstructive symptoms, some are storage symptoms. So the storage symptoms mean frequency, urgency, nocturia. Obstructive symptoms, straining during micturition, sense of incomplete evacuation, hesitancy, intermittency. These are all obstructive symptoms. Now, duration. Duration is very important. Short duration, very short duration, acute onset symptoms. These are mainly due to infective causes or any stone or mm, these sort of acute symptoms. But long-standing duration is mainly caused by chronic causes like BPH, urinary strictures, all these things. Now, current urinary symptoms, storage symptom. Either I was told that whether it is storage symptoms or voiding symptoms, that is the obstructive symptoms, changing symptom severity over time, how it is changing. Now, previous any history, whether there is any history, sometimes he may not have a prostatic pathology. He may have some urinary stricture, urethral stricture. Then that may cause um, this lower unit tract symptoms. So, previous any history, persistent recurrent UTI, indwelling catheter insertion, previous surgery, suppose previous TURP or TURBT, I mean, parurethral instrumentation, history of parurethral instrumentation is very important. It may lead to urethral stricture. Now, and also important current medical treatment, which give you important clue that whether patient is taking any alpha blocker or not. So that means he is having some prostatic problem. Now, physical examination, generalized examination, edema, pallor, and all these things, scar over the abdomen, suggest of previous urologic surgeries, suprapubic dullness or distended bladder, we call it suprapubic bulging. This means there is chronic obstruction. Patient is having some chronic obstruction which is depicted by suprapubic bulging, and we clinically we can elicit with on inspection the suprapubic bulging, and on palpation you can elicit it with suprapubic dullness. And you should also examine the genitalia. What is important for us urologists is parectal examination. This is very important in a patient of LUTS, lower unit tract symptoms. Parectal examination, you also find it in the surgery wards and also surgery um, classes. That parectal examination is very important. So what on urologic point of view, what important points you should know, that the tone of the sphincter, that is sphincter anal sphincter tone is very important. Why? Because anal sphincter tone is reduced in some neurological causes, maybe due to long-standing diabetes, maybe due to spinal injury, whatever be the cause. If there is reduced anal sphincter tone, it indicates there is some neurological component which may cause these lower unit tract symptoms. Condition of the rectal wall and other rectal pathology you can elicit according to uh, uh, it is obvious. And you should observe with your finger, and after removal of the finger you should see whether there is any blood. And regarding the prostatic palpation, you should assess volume, consistency, contour. Contour is very important. If the median depression is lost, that means it's the enlarged prostate. Consistency is very important. In case of prostatic malignancy, we found it hard, stony hard prostate. Sometimes hard nodule can be appreciated through particular examination. And in case of BPH, mainly we found it firm. Firm means soft to firm. That is the feel you feel the tip of the nose. That's consistency, or is um, BPH prostate. But in case of prostatic malignancy, it becomes stony hard. And volume assessment with parectal examination is a very gross assessment. We just can appreciate a circumference, part of the circumference of the prostate. Prostate is not a smooth round ball. It is a pear shaped. You know that. So we assess the only one part of the circumference of the prostate, and with that we assess, we predict how much size of the prostate would be there. But the actual size, actual volume is measured with ultrasonography and other investigations. Now, symptom score I discussed. Now the management, the investigation part. We start with urine analysis. This is very important in any lower unit tract symptoms. Don't think that every lower unit tract symptoms patients comes and you will prescribe him alpha blocker something. This is not the way to treat. You first think that the person may have any sort of condition that may cause lower unit tract symptoms. It may be a UTI, simple UTI, which causes lower unit tract symptoms. So don't do in your future practice that a patient complaining of some lower unit tract symptoms and you are prescribing him some alpha blocker, tamsulosin, on silodosin, and all these things. Don't do it. So first of all, you take history examination, and then you will get some idea that what may be the cause of these lower unit symptoms. After that, you do a urine analysis. Urine analysis gives lot of information regarding your diagnosis. First, whether there is any infection, that is pus cells. Parcels is very important. More than 3 to 5 parcels is significant. And but what is important in urine analysis, that you should instruct the patient about the collection of the sample. Collection of sample is very important, especially in case of female patients, because the common cells organisms comes. So urine analysis, we usually prescribe, do routine and culture examination, but just don't advise them how to collect urine. That is very important. First of all, you should advise the patient to take the midstream morning urine sample. Midstream morning urine sample. Midstream means you have to urinate a bit, and then the sample will be collected. The mid part of the urination sample to be collected, it will be collected in a jar supplied from the institution where it should be investigated. So the institution will give you the wide mouth container for collecting. Any room container is not recommended. So you take it, and you advise the patient to collect the first morning urine sample. Second thing important is you have to advise the patient to wash his or her private part with normal running tap water. Normal running tap water, because any soap or antiseptic is not recommended. So you wash your private part, urinate a bit, and then you collect the urine. That is very important. And midstream urine, and you have to submit it to the institution within 2 hours. Within 2 hours, and if you thinks that it will take more than 2 hours, then you have to preserve it with eyes and all these things, because otherwise culture report will not be there. So these are the common things that we should advise during advice of urine analysis. Now in urine analysis you will get microcrystals. In case of stone diseases you get specific gravity, that is more, also very important. You get past cells, you get um, RBCs. RBCs is also more than two RBC in hyperoxia is significant. So now optional investigations are fee, Euroflow, and post-void residual urine. These are optional. Euroflowmetry gives you the urinary speed, ml per second. How many amount of urine per second is voided. Voiding diary is very important to discuss, to differentiate different causes of lower unit tract symptoms. So voiding diary is a very simple investigation. Patient can note it, but it is commonly not. Yeah. PSA, I will have to some discuss about PSA, because PSA comes as a short note, but it is also regarded as optional. Not all patients require PSA. Prostate ultrasound scan. Prostate ultrasound scan is optional. You can do it. You can not recommended. Serum creatinine is not mm, recommended. And upper tract imaging is not required. There are some specific indications where upper tract imaging, like CT scan of the kidney, ureter, and bladder, or ultrasonography, which suits the patient, is recommended. So, so main investigations are digital rectal examination, IPSS score, creatinine measurement. Creatinine measurement is optional. I told you. Flow rates, flow rates is also optional. Post-varicose volume is also optional. Now, is PSS screening mandatory? Sometimes it is asked whether it is not mandatory. No increased risk of prostate cancer in patient with LUT is screening not mandatory. Screening should not be physician initiated. You should discuss the patient. Shared and informed consent decision making should be there. Patient should be counseled, because PSA, when I will discuss PSA, PSA has got many, and prostate cancer is not a cancer like lung cancer or liver cancer that patient will die within 6 months, 1 year. It's not that. So PSA is a very slow growing cancer. So you should assess whether the patient actually needs to be treated for prostate cancer or not. So that's why PSA is not just patient comes and you advise PSA. PSA is not a investigation like that. Now, risk of overdiagnosis or over treatment. So a patient comes with high PSA and you stamped it as a prostate cancer. Sometimes it is overdiagnosis. So single value is not enough, because it is not very specific. So that's why you should use it with caution. Uh, it should be life expectancy should be more than 10 years, because more than 70 years patients does not require any PSA assessment, because it is not recommended. And sometimes it is done when you think that the management protocol can be changed, may be changed with PSA. So in that case, you have to do PSA even if it is more than 70 years. Now, I was talking about frequency volume chart. Frequency volume chart is very important to differentiate different causes of lower unit tract symptoms. Here, the patient notes the time when the patient it is mainly done in the storage symptoms patients. Patients mainly points mainly here it write down the time when he passed urine, during the time when he passed urine, and whether there was urgency or not. So time and amount of urine, and there is urgency or not. And it is fluid intake, time, intake. So with this chart, 24 hours intake output chart, you can diagnose a lot of things, but commonly it is not done. Now, in an upper tract imaging, I was telling you, upper tract imaging is not mandatory in case of lower urinary tract symptoms. So, what are the indications where we should do? Mm, the indications are hematuria. If the patient is having hematuria microscopic, previously I was taking a class on hematuria. Any microhematuria or gross hematuria, upper tract imaging is a mandatory. So, history of UTI mainly in male patients and recurrent UTI in female patients. You have to do upper tract imaging. Renal insufficiency patients, patient having high creatinine level, history of urolithiasis, previous history of urolithiasis and history of urinary tract surgery. These sort of patients require upper tract imaging. Management, in management, the BPH patients, how you manage. First of watchful waiting. Previously, I was saying about the symptom score, IPSS score. So, if the patient is having low IPSS score, less than 8, you may not give any drug. The only lifestyle modifications can improve the patient. If he is having any associated UTI, you treat the UTI and patient improves. If the patient is having something mainly nocturia, you advise the patient to reduce his fluid intake after 7 p.m. Reduce his fluid intake. Advise him to take fluid in the daytime. In the daytime, that patient improves. If the patient is not and one thing is important, whether the symptoms bothering the patient or not. That is very important. If the patient is a retired person in the home and the symptoms are not that much irritating him, he is okay, normal with him with these symptoms, you may not treat him. And but if he's a executive and he is working where frequent urination bothers him, he hampering his day-to-day activity. Nocturia bothers his sleep and becomes daytime sleepiness. So these things should be borne in mind before prescribing medicines. Mainly moderates to 8 to 19, mainly moderate uh, and severe, more than 20 IPSS score. These patients requires treatment. So watchful waiting is with lifestyle modification is treatment policy in case of mild symptoms. Now, pharmacological therapy mainly we prescribe alpha blockers. What is alpha 1 blockers? These are tamsulosin, silodosin, these group of drugs we prescribe. How it helps? It actually relaxes the neck muscles. It is a muscle relaxant. Neck muscles are relaxed, and the flow of urine increases. 5 alpha reductase inhibitors. 5 alpha reductase inhibitors, it is commonly prescribed along with alpha blockers. 5 alpha reductase is the enzyme which converts testosterone to dihydrotestosterone. Dihydrotestosterone is the active molecule, and testosterone is a stimulator of the prostatic growth. So, if we can inhibit the 5 alpha reductase enzyme, that the conversion of testosterone to dihydrotestosterone is hampered, so the prostatic size is reduced. So 5 alpha reductase is commonly used along with alpha blockers in case of large prostate. Less than 30 grams prostate, you don't need to give 5 alpha reductase. It does not have any seizable effect. So large prostate like 50 grams, 60 grams, 100 grams, these sort of prostates, 5 alpha reductase inhibitors, they are helpful. It reduces the size of the prostate. And combination therapy, I told you that combination therapy is commonly used in large prostates. A small prostate, alpha blocker, only alpha blocker is sufficient. And role of phytotherapy, there are some phytotherapy is also it is written in the literature, but we don't advise patients with phytotherapy. Now, surgery, because you see the question mark Phytotherapy is not got a feasible effect. Now surgery is standard is TURP, that is transurethral resection of prostate. We usually do, this is the gold standard at present still, though there are many comparative techniques have come, but TURP is still regarded as the gold standard. What we do is we cut the prostate transurethral from inside. We scrape the prostate piece by piece, and we remove the prostate from inside of the urethral side of the prostate. So commonly it is done with monopolar diathermy. It's called monopolar. We use glycine as the irrigating fluid, and there is also called bipolar TURP, where we use bipolar current. There are advantage of bipolar TURP that we use normal saline as the irrigating fluid. So, in case of monopolar, we use glycine, which is not physiological. So, there is a chance of TUR syndrome in case of monopolar TURP. But bipolar TURP, we use normal saline as a irrigation fluid, which is physiological. That's why chance of TUR syndrome is low, but you cannot say that it is nil. There are some incidents where TUR syndrome has been seen with bipolar TUR. Mobile term? Mobile term? We have seen some incidents with TUR syndrome with bipolar also. So now and uh, monopolar TURP, bipolar. Another is nowadays laser. Laser is, we use holmium laser. We have one holmium laser in our institution also, which is called HOLEP. Holmium, we enucleate the prostate with holmium laser. It's called HOLEP. Holmium laser enucleation of prostate. So it is we don't cut the prostate piece by piece. In this case, we enucleate the prostate from the capsule, and we push it inside the urinary bladder. After that, we morcellate it. Means we there is an instrument called morcellator which makes these prosthetic lobes uh, mm, into meshed product, and it is sucked out from the bladder. So HOLEP is commonly done in large prostates. Is another technique. And now there is there is open surgery is also there. Open surgery nowadays is mainly done in case of large, very large prostates, which monopolar is not recommended because TUR syndrome. But bipolar TURP you can also do in large prostate, because with bipolar TURP you can cut a long time, and you also can stage the procedure in large prostate. It is not that large prostate means open surgery or HOLEP. You can do it with monopolar or bipolar TURP also. You have to stage the procedure. That means two stage of procedure we have to do. Now this is the surgery. Watchful waiting, I was saying, IPSS score less than 7, small prostate, and not affecting quality of life. Bother is minimum. I have discussed is all these things. Alpha blocker, it reduces IPSS score 4 to 7 points. That means you can well appreciate a patient with 12, or there is moderate symptom score. If 7 points reduction is there, it becomes mild score. So patient improves with alpha blocker. Peak flow rate improvement is 1.9 to 2.5 ml per second. No change is prostate volume. Alpha blocker does not change the prostate size. It is done by 5 ARI, that is 5 alpha reductase inhibitor. Does not alter the natural history of BPH. It just relaxes the neck muscles so that the flow is increased. Now, factors predicting poor outcome with medical therapy. Which are the patients where you may advise surgery to a patient, because medical therapy is may not give good results in these cases. Uh, One is age greater than 65 years, enlarged prostate volume more than 30 ml, increased serum PSA 1.5 nanogram per ml, high prostate post-void residual urine volume PVR greater than 50 ml, baseline LUT severity IPS score more than 7, low peak flow rate less than 12, intravesical protrusion more than 1 centimeter. So these are the points we should keep in mind. What are indicators of surgery? Surgery indications are very clear. Refractory urinary retention. That is means patient is having repeated urinary tract retention and failed trial of withdrawal of catheter. Renal insufficiency. If the patient is having bilateral hydroureter nephrosis, high creatinine, so you don't um, depend on the medical therapy. You should advise him surgical therapy. Renal insufficiency is indication. Recurrent UTI. Patient is suffering from recurrent UTI, which the cause is no cause is found except high prostatomegaly. So this is the indication for prosthetic surgery. Now, persistent gross hematuria. This is very important. Persistent gross hematuria, where no cause is found except prostatomegaly. So this is the indication where you can do a prosthetic surgery. Bladder stone due to bladder outlet obstruction. Patient is having a prostatomegaly with prostatomegaly with LUTS with having bladder stone. So this is indication for surgery. Failure to medical management. Patient is not satisfied with medical therapy. Patient is taking medicine and he is not satisfied. The improvement is not satisfactory, or he was previously satisfied, but nowadays he is not satisfied. So this is the indication for surgery. Cost and compliance of the chronic medication is also important factor in case of in our sort of society where you can have prosthetic surgery done in a hospital free of cost, but these medicines are very costly. 30 rupees, 25 to 30 rupees a tablet. So patients cost and compliance of chronic and these are all symptomatic drugs. I mean, if you take the drug, you are symptom free. If you stop it, you will have same problems. So a continuous expenditure of expenditure is required to get relief. So sometimes surgery is an option for these patients where surgery is done free of cost in the government hospitals. So unsatisfied with medical management, some people are not satisfied, and unacceptable side effects with medical management. So that's why I was telling that if the IPSS score is less than 7, that is mild symptom score, and patient if not bothered, so you don't prescribe medicine, because uh, these medicines have got side effect. You will see that the alpha blockers has got first dose hypotension. I mean, patient taking we always advise these alpha blockers to be taken at bedtime. You take the medicine and go to sleep, because it has got hypotensive property. Patient alpha blocker causes hypertension, and if the patient is taking antihypertensive along with it, patient may suffer from blackout. Patient may fall. So that's why these alpha blockers are advised to take during bedtime. You advise the patient to take it and go to sleep. Uh, so this is this also causes retrograde ejaculation, alpha blockers, because for younger patients this is a problem. So you a patient complaining of mild symptoms and you don't prescribe alpha blockers straightforward. You assess it first, try to point out the cause and then prescribe. One drug is alfuzosin, which is also a alpha blocker, which has got reduced incidence of retrograde ejaculation. So younger patients, we advise alfuzosin in place of tamsulosin. So this is another point you should keep in mind. So this is a nutshell. This chart is very important for your theory exam. If you can write like this is a good way of presentation. rather than writing a lot of pages. So LUTI patient, moderate to severe symptoms. Moderate to severe symptoms is very important, which requires treatment. Otherwise, lifestyle modification and UTI treatment, all these things, these are sufficient. No significant bother. Small prostate, watchful waiting. You don't need to treat prostate. Large prostate, watchful waiting, or 5 ARI. 5 ARI will reduce the size of the prostate. Okay, so the patient is not no significant bother. That's why we are not giving alpha blocker here. But if significant bother is there, so you have to give alpha blocker. Small prostate, alpha blocker, surgical therapy. Alpha blocker here, ARI not given because small prostate, ARI no role. ARI only 5 ARI only reduce the size of the volume. So large prostate, you use combination therapy, alpha blocker, large prostate and significant bother. Alpha blocker will reduce the botherness, that is symptomatic treatment, and large prostate will take care of a 5 ARI. So combination therapy in this category only, and you can advise surgical therapy also. So this is a nutshell the management, the treatment protocol in a patient of LUTS. Okay, so now sir told me about about urinary detention. So here some slides from Dr. Kekre's presentation, which I think very important. You should know these things, and again I will discuss retention in another presentation. So now an acute painful inability to void with a distended bladder. The acute urinary detention. What is acute urinary detention? It is an acute painful inability to void with a distended bladder. That is very important. Retention means you have to a distended bladder. That is important. Classification is spontaneous. There's no preceding factor. Sudden acute means sudden. Acute retention means sudden. You have developed this retention suddenly, but it may be spontaneous, not any preceding cause, or precipitated, triggered by events like surgery, UTI, alcohol consumption, over distension, etc. So these things should be kept in mind. Now, etiology is obstructive. Obstructive etiology is maybe due to mechanical obstruction, BPH, stricture. Dynamic obstruction may be postoperative pain, drugs, BPH. These are neurological interruption of sensory or motor innervation to the bladder, pelvic surgery, multiple sclerosis, spinal injury, diabetes. So, neurological cause may cause acute urinary retention. Myogenic, over distension of the bladder, post anesthesia, high alcohol, patient forget to urinate and the bladder distended and precipitated acute urinary detention. The presentation is painful, palpable urinary bladder. Here, painful is very important. In acute urinary detention, you get a patient with painful bladder, but chronic retention patient is unaware. You see a large lower abdominal distended bladder, but the patient is not bothered. So this is chronic retention. Acute retention, always it will be painful. Volume drained is usually less than 1 liter. In the contrary, in chronic retention is more than 1 liter. No renal failure. Renal failure, there is no renal failure in acute retention. Initial management is catheterization, pariurethral or suprapubic. You have to give silicone or latex catheter care. I will discuss this in a next presentation. Investigation mainly USG, KUB, X-ray, KUB, laboratory, serum creatinine, urinary microscopic and culture examinations. These are all investigation. Now trial without catheter. Now you patient comes with acute retention. There is no chronic retention. Now how much to how far you will continue catheterization? No. So you cannot you cannot say that you leave rest of your life with catheter. Now you have to give trial. Before trial, you should investigate the patient. What are the investigations I told you? The USG, KBP, X-ray, X-ray to see whether there is any stone or not. So if there is any stone in the bladder, you cannot remove the catheter because again it will be precipitated. If it is a high volume prostate, you have to manage the prostate according to the either you have to give medicine or you give surgical treatment. Then you remove catheter. If he is he or she is having bladder tumor, you have to treat the bladder tumor. Otherwise, again, it will be precipitated. So if there is no treatable cause is found, then you have to think to remove the catheter. Now, what are the important points that during trial of catheter? Indication: initial episode AUR due to BPH. You diagnose that this patient AUR is due to BPH. So you can give a trial of catheter. Absence of upper tract dilatation, renal failure. If there is upper tract dilatation, hydronephrosis is there, ureter is dilated, renal failure is there, you have to go for surgical correction, surgical TURP you have to do, and then you try to remove catheter. Absence of adverse prognostic factors. Adverse prognostic factors, that is, I told you that these are all tumor and all these things. That means patient will not improve. Patient condition is poor, the future is poor, so you don't remove catheter. Why? Contraindications: upper tract dilatation, renal failure, same thing. Chronic retention. Chronic retention, you have to treat it. Recurrent AUR. Recurrent AUR, you should be very cautious, because recurrent AUR due to prostatectomy is an indication for surgery. So you don't advise trial, because it will fail. It is first time the success rate of trial of catheter is high with first attempt. In second attempt it reduces gradually. So what are the predictors of failure of trial um, of withdrawal of catheter? What is the long term outcome? So success rate is 60% in alpha blocker compared to 46% with placebo. So there is definite increase in success rate with alpha blocker. We advise alpha blocker 3 to 4 days before trial. And long-term success rate TWC is low. The majority with a successful withdrawal required surgery in later life. TURP within 2 hours is 57%. 57% of the patients usually require surgery if the patient has suffered acute urinary retention due to prostatectomy. Now, what are the predicted outcome? Mm, age. Increased age is not good. Spontaneous retentions, the result is not good. Prostate size greater than 40 grams, result not good. Initial volume of urine drain more than 1 liter, result not good. Intravesical protrusion, that is the median lobe enlargement inside bladder, is more than 1 centimeter, the result is not good. So these sort of patients are managed better with early surgery. So failure of TWC, absolute indication for surgery. TURP remains the gold standard. And now chronic retention, painless distension of the bladder with significant residual urine. There is significant residual urine more than 1 liter. Cutoff value of high PSR is more than 1 liter. Classified chronic retention, chronic retention is classified as high pressure chronic retention, low pressure chronic retention. Now, high pressure chronic retention means the retained urine is having high pressure. Why it has been classified with this pressure theory? I mean, what is the importance of pressure of the fluid? If it is high pressure chronic retention, that means the urine inside the urinary tract is with high pressure. It gives a back pressure to the kidney. Okay, so back pressure changes occur in the upper tract. That is, upper tract means kidney and ureter, and that leads to hydronephrosis and subsequently chronic renal failure. That is the most important thing. So if the retention is high pressure system, then the patient can suffer from renal failure. Patient may suffer from renal failure. That is most important. So mm, the pressure rise during filling is more than 25 centimeter of water. Hypertension, nocturnal incontinence, palpable painless bladder. So another thing you should keep in mind, that there are some check system. I mean, this high pressure causes hydronephrosis. So to reduce the ill effect of high pressure urine, the nature has given some has some safety valve mechanism like circulation in the bladder. The bladder there becomes the circulations arises in the bladder, which um, reduces the pressure of the urine. And there is also system in the kidney also. There is rupture of the thin layers, which causes urinoma formation, and the kidney is safe. So these are the some mechanisms by which the pressure is reduced. The idea of this, so that the kidney is not damaged, that is the most important part. And the low pressure retention may be asymptomatic. Patient is not bothered, have low volume micturition, and increased frequency, palpable, painless bladder. Painless is very important in chronic retention. Usually, this patient does not have renal failure. Trabeculations, the compensation. I was telling about the compensatory mechanism. One is trabeculations. There is saccule formations inside the bladder mucosa, and pockets of mucosa pushed in between muscle bundles. These are called trabeculations. Diverticular formations, saccule formation, and decompensation, detrusor leading to high PVR. After some time, it becomes decompensated. And the PCS dilation and hydronephrosis occurs, trigonal hypertrophy across terminal kidney, parenchymal atrophy. This leads to kidney chronic renal failure. Ultimately, hydronephrosis and followed by parenchymal atrophy. So this is the natural history of high pressure urinary detention. And low pressure, because the bladder is very much compliant, so it increases in size, so the pressure does not increase. No upper tract dilatation. Chronic retention is diagnosed painless bladder distension, initial drainage greater than 1 liter, more than 50% have renal failure, upper tract dilatation. Initial management is catheterization, serum creatinine more than 2 milligram percent, hypertension difficult to control in these cases. What complications may occur post catheterization? After you catheterize the patient, what are the complications may arise? Now, problem. Sometimes the patient comes in the emergency department with retention, and a resident just catheterize the patients, and don't look at the patient and go home. That is the problem. These things you should keep in mind, that what are the problems may arise after successful catheterization. Immediate post obstructive diuresis in a chronic obstructive patient may suffer from diuresis, so you should advise the patient that you may have very large amount of urination after you have removed the urine from the bladder, but the patient he was suffering from chronic retention, he will have post obstructive diuresis for a few days. Now, decompression hematuria, this is very important, patient may die of it. Decompensation, the bladder was enlarged, you have catheterized the bladder, and you reduce the volume. I told that more than 1 liter of urine is that defines chronic retention. So a patient with large suprapubic bulging, you catheterize the patient and go. No, you decompress the bladder slowly. Slow decompression is recommended. Now, what is slow decompression? How you slowly decompress the bladder? Sometimes the Eurobag is kept above the level of the a bit high level, so the transfer of fluid from the patient to the bag occurs slowly. But there is a problem is, you have to observe, because if you put the bag above, the urine will backflow. So it is not important. The important is, you have to change the level of the bag according to the clearance of the urinary bladder. Another thing is, you intermittent clamping. You open the clamp of the uro bag, wait for some time, and then clamp it. Wait for some time, decompress a bit, another clamping. The intermittent clamping. Through intermittent clamping, you can decompress the bladder slowly. So a patient coming in the emergency department with retention, be it acute or chronic, you catheterize the patient and advise slow decompression, because it is in the history some people have died due to this decompression hematuria. And maintain no fluid overload, normal vitals, monitor urine output, because these patients suffer from post obstructive diuresis. So you have to you have to monitor the urine output. And serum electrolytes is very important, because these patients suffer from electrolyte imbalance after catheterization. So serum electrolyte measurements are important. Allow free access to electrolyte supplemented fluids. The patients are advised to take fluid as and when becomes thirsty. So this is important. The intravenous fluids are usually unnecessary. Signs of fluid overload: poor cognition, azotemia, hypotension. These are signs. Fluid overload. Intense monitoring vitals 4 hourly. You have to observe the vitals for indwelling catheter unit output hourly. Serum electrolytes, blood urea nitrogen, magnesium, creatinine 12 hourly. Urine osmolality is very important, because these patients, the osmolality is low. IV supplementation is not usually required. Initial urine isothenuric, that is sodium approximately 80. The concentrating ability of the kidney has lost. Replacement with 0.45% saline is recommended. So this is level 5 evidence. Level 5 means expert opinion. Now, management of post-obstructive diuresis with hyponatremia. So post-obstructive diuresis, patients suffering from post-obstructive diuresis with hyponatremia. So how you will manage? So calculation of the sodium deficit with this formula. The stop IV fluid as soon as the patient is stable, oriented, able to drink sufficient. I told you that. Advise the patient to drink when he is thirsty. And you measure the sodium, potassium, and other electrolytes, and supplement with the oral fluid. That is the most uh, effective treatment, good way of treatment. But if the patient is cannot able to take fluid perorally, then you have to give for consider for IV fluid. And BPH, conservative management of BPH after you are not advisable, may be attempted very rarely. Patient is unwilling for surgery, no obstructive uropathy or detrusor failure, strict follow-up to avoid progress. When to operate? This sort of patient, chronic retention, when to operate? Now, optimize the patient. Give some time to optimize the patient, 4 to 5 weeks. Comorbidities controlled. Creatinine has come down. But for how much? Usually 4 to 5 weeks, usually a month. You counsel the patient that may have refractory retention after surgery. Uh, Failure to void. You have given trial, patient failed to void. What to do? Next, what to do? Now recatheterize the patient. If the patient cannot void, you have to catheter. That's all. Now treat the other cause. You have not found any cause. That's why you are trying. You are given a trial. So you have not found any cause. You have given a trial, but again patient cannot void. Now what to do? Now you recatheterize the patient. Now you consider other causes which are not common, like constipation, pain, perineal pain, UTI. So second attempt not if second attempt also is failed, then you have to do cystoscopy. You have to do cystoscopy to check the residual prostate, how much prostate is there. After cystoscopy, if cystoscopy is normal, then you have to think for urodynamic study. You have to do urodynamic study. Thank you. Now, again, I uh, I am supposed to. Mm, एक minute. Mm, I should say something about retention. Sir told me to say about retention. Now, I am telling about something. I discussed a lot of things about the retention, but the practical purpose for retention, I told you acute and chronic. Now, the causes of retention is neurogenic, myogenic, psychogenic, idiopathic. This is the bladder cause. Another is outlet cause. Outlet means urethra and neck. This is the anatomic obstruction in the neck, prostate, urethra. Functional is sphincter dyssynergia, non-neurogenic dysfunctional voiding, and another is combination of these two. So I have made this presentation keeping in mind the theoretical questions. So and also some practical is there in later you see. Now a patient comes with retention. So what you'll do? First examination, general examination, vitals. You have to see whether the patient is having some problem that should be taken care of earlier. So general examination is very important. Now specific examination, meatus. You have to see meatus. Don't advise catheterization if the patient is having meatal stenosis. It is not possible to introduce the catheter. So before advising catheterization, you should observe the meatus, whether there is meatal stenosis is not. Now the urethra, there is a stone stuck in the urethra. If you can palpate the stone, you cannot introduce the catheter. So you should see the urethra, parectal examination. If you suspect a high, hard, large prostate malignancy, so difficult, the patient will have catheterization can be done. The suprapubic bulging you have to assess, and neurological exam, focal neurological examination you should do. Now, PUC and SPC, what to do? PUC means parurethral catheterization. I told you where you can do parurethral catheterization. This is better. In an emergency setup, you don't need to operate. You don't need to do anything. You just put a catheter. Now, how you put a parurethral catheter? That is important. Now, first is aseptic dressing and dripping. This is commonly forgotten. Aseptic dressing means you dress with betadine lotion. 10% betadine lotion is you give, and draping. You take a cut sheet to drape properly so that the catheter and these things are not contaminated. Now lubrication, very important. We use 2% xylocaine lignocaine gel as a lubricant. It is not used as an, though it is anesthetic gel, but it is used as a lubricant. Some people takes paraffin in the words, which is highly contaminated. Is not at all recommended. So, what lubrication you use, it should be hygienic. I mean, it should not be contaminated. So, lubrication is very important. Now, how you lubricate? You can see that your seniors putting some gel over the dorsum of his pump and lubricating the catheter. This is not the way. You should lubricate the urethra, not the catheter. Mind it. You should lubricate the urethra. So put the tube nozzle inside the meatus and press the tube so that the gel go inside the urethra and milk it so that the gel goes inside the urethra. Otherwise, you take a 10 cc syringe and put the jelly inside the syringe and push it through the meatus. So this is the proper way of lubrication. You should not lubricate the catheter. You should lubricate the urethra where you will put the catheter. Now, selection of catheter. Selection of catheter is important. Uh, if you want to keep the catheter for long, you should choose a Foley's catheter, which is self-retaining catheter. If you want to catheter single catheterization is required, you can simple rubber catheter you can take. So selection is important. The purpose of catheterization will say you size of the catheter, which size you will, according to the age of the patient or according to the urethral caliber, you have to choose a ideal size of catheter. And also important is which what is you want to drain. Suppose the patient is suffering from hematuria, so you have to take uh, a wide bore catheter so that the blood can come out. But if you want to drain urine which is clear, you don't need a large bore catheter, because the large bore catheter will cause urethral stricture in future. So selection of catheter is very important. Now, how you introduce? Dressing, draping done, lubrication done. Now you hold the penis with your left hand if you are a right-handed person, or you separate the labia majora of the female patient with your left index and thumb, and with proper light you should introduce the catheter. You should introduce the catheter through the urethral meatus. Now, confirmation. You have put the catheter. Now, how you confirm that the catheter is inside the bladder? First is urine coming out through the catheter is the important point. Now you put the catheter, you think that it is going inside, total catheter has gone, but urine is not coming. So what to do? Why it is not coming? Sometimes it happens, urine does not coming. So some people inflate the catheter balloon. Some people suppose thinks that it is not inside the bladder, and again reinsert the catheter multiple times. So after introduction of the catheter, if you pull it out and again put it inside, the chance of infection increases. And if you inflate the balloon without confirming that it is inside the bladder, it may cause urethral rupture. Commonly, the prostatic urethra is ruptured. So, what to do? You wait for some time. First thing, you should observe that after complete insertion into the bladder, whether the catheter is coming out as a like retropulsion. I mean, it is coming out. Whenever you're trying to push it inside, it is coming out. That means it is not inside the bladder. If it is inside, the tip is inside the bladder, it will not come out. Second thing, the urine is not coming out. Wait for some time, because the gel you have used for introduction of the catheter may cause have occluded the lumen. That's why urine is not coming. Wait for some time. Otherwise, you can inject some water through the channel of the urine so that the gel washes out and urine comes. So better you wait for some time and then put some pressure in the suprapubic pressure as the urine comes. But if urine is not coming and you are giving suprapubic pressure, urine is not coming, and there is some doubt that the there is catheter is coming out whenever you are trying to push it inside, or there is some doubt, don't inflate the balloon. Even if you inflate the balloon, inflate with small amount, 5 ml. Okay. After confirmation, you increase the volume of the balloon to 10 ml or 15 ml. Okay. So don't take it granted that it is gone inside the bladder. So you're very cautious. I have seen one intern in medical college whose father was suffered from uh, urethral rupture after catheterization and balloon inflation. So it was done by another intern. So you be very serious about this catheterization. Now confirmation. Now after that you inflate the balloon. We usually give 10 cc of water. That is sufficient. Prepuce deposition. This is very important in male patients. You reposition the prepuce, because during catheterization you have to retract the prepuce. If you don't reduce the prepuce, then patient will suffer from paraphimosis. This is a very negligence on the part of the treating doctor. So always remember, in male patients not circumcised, always reduce the prepuce. Is very important. Now in SPC, suppose patient having mitral stenosis or urethral stricture, or the patient has come with rotary accident, you cannot negotiate a catheter. There is injury in the urethra. So what to do? You do SPC, suprapubic cystostomy. Now suprapubic cystostomy steps, again dressing and draping. You dress and drape the suprapubic region, that is lower abdomen. Now site selection. Site selection is very important. We usually found it is written the above, two finger breadth above the pubis, symphysis pubis. So, but commonly people try to put the trocar as close to the pubis as possible, just to prevent gut injury. If you go close to the pubis, you prevent gut injury. That's why you go. But problem is that in future, if we try to do cystoscopy, this is very difficult. If you have a super big opening just above the pubis, to do cystoscopy is very difficult. So two finger, generous two finger. Sometimes we advise midpoint between umbilicus and the suprapubic and the pubis. But for all practical purpose, for your undergraduate examination, you always say two finger breadth above symphysis pubis. Now, if suppose there is a scar over the abdomen, previous suprapubic scar, or um, there is some injury in that part. In that case, you have to change your position. Now, if you have to change your position in these circumstances, you have to go above or below. Now, in these cases, you cannot do blind suprapubic cystostomy. You have to um, take help of the ultrasonography. You have to take help of the ultrasonography so that there is no gut injury is there. Now another important thing is now you selected the site. Now what will introduce is two types of things are there. One is trocar cannula. What we use is a instrument, trocar cannula. You choose the catheter which you will use in the trocar for supervision. Confirm it whether the balloon is not leak. So inflate the balloon outside. Confirm that the balloon is good in good condition. Now you have selected a site. Always put the suprapubic trocar in a distended bladder. Bladder should be well distended. If it's not well distended, wait. You have to wait for well distended bladder so that there is no gut injury. Now you give a incision. First of all, give some local anesthesia. in below the skin and also below the sheath, anterior sheath. So these two are pain sensitive structures. You incise the skin and also inside the skin, and then you introduce the trocar. You trocar through the trocar, with the trocar you puncture the anterior abdominal wall, and then you puncture the bladder wall, and you go inside the bladder. After that, you open the trocar, cannula is inside. You put the catheter through the cannula. Total catheter is put inside, then inflate the balloon. After that, you remove the cannula. Keep the catheter inside. You remove the cannula slowly, and after that, you pull the catheter so that the balloon compress the site of puncture. So, and you wait to see the color of the urine. That is important. Now you fix the catheter in to the with the abdominal with suture. So catheter fixation is also important. In case of supracath, you don't have to do this trocar cannula system. You just incise the skin. The supracath itself has the trocar inside the catheter. So you with the supracath system, you puncture the abdominal wall and bladder, go inside, put out the trocar, and the cannula is the catheter. So you inflate the balloon, take out the trocar, and connect the urobag with the cannula. The supracath cannula is the catheter here, and you fix it with the abdominal wall. So this is the steps of suprapubic cystostomy, and I told in previous presentation that suprapubic cystostomy or catheterization, you wait, observe the patient for post-operative obstructive diuresis and hematuria. This is very important. So I think this is enough for today. Another, I failed to discuss about PSA. Another presentation was there. But anyway, is there any question? Hello? Hello?
Yes, sir, there is a question. I'll post it in the chat box.
Okay, okay, okay. What is the chat box? Uh, uh, chat box, I mean, um, wait a minute. I cannot found it. Mm, participant, for share, remote control. Can you tell me what is the question? I am not finding it. I found it. Question was Shubha Bhattacharya, sir, what do you ask to elicit urinary urgency history from a patient? Now, urgency, I told you, uh, it is uh, it is the desire compelling desire to urinate, which is difficult to defer. That means patients find it is very difficult to check the desire of urination. So we ask the patient that is there any incident that you have difficulty in holding your urine? So patients in Bengali, I tell them কখনো পেচ্ছাপ চাপতে খুব অসুবিধা হয়েছে? Uh, Usually patients say that it is difficult to check urination when when he feels and desire to void. By definition, it is the compelling desire to void, which is difficult to defer. That is called urgency. And sometimes patient says that two to three drops expels before he go to toilet. So that is called this is called um, uh, incontinence. This is called urge incontinence. When he feels that it is difficult, but he goes to toilet and voids, this is called urgency. But when he urinates two to three drops before going to toilet, it is called urge incontinence. Okay, I think it is done. Excuse me. In the
Yes, sir.
can you tell me how many students were there in today's class?
Uh, Dhwani ma'am.
Just a second. I'm telling. 16 students.
16 students. Okay. Now I just close it. Okay. Can I close it?
Yes, sir.
Okay.